thank you for the introduction, and thank you for the organizers for inviting me to be part of this talk today. So we're going to kind of jump right in here to clinical deep dive, looking specifically as Rezdiffra as a treatment option for patients specifically with non-cirrhotic, I want to stress that, MASH, with known moderate to advanced fibrosis in conjunction with lifestyle. And thank you for our previous talk, because it was a wonderful disease state segue into this portion of the evening here. So this portion of today is a promotional educational activity that is not for CME. It is in line with Madrigal Pharmaceuticals label and with FDA requirements for this product. And I am a consultant for Madrigal. So what are our goals for today? An overview of MASH with fibrosis, consequences and progression, which we've already seen some of that in our previous talk. Specifically looking at thyroid hormone receptor beta, mechanism of action, which is a specific pathway that's liver-directed in reducing steatohepatitis and fibrosis. Looking at the dual efficacy endpoints that are required to achieve approval for a product like this, which is a pretty rigorous endpoint that the FDA requires. And I think up to this point, there's been different molecules that have tried to achieve this and haven't been able to, whether they fell short of those endpoints or had safety concerns. So it really is great to have this novel product available that we've been waiting for. A nice, clean, demonstrated safety profile, and I can't stress that enough, given the prior attempts to get here. Nice, easy, once-a-day oral dosing, and how patients access this product. So looking at MASH specifically with fibrosis and looking at those consequences and progression. And so I will often say that I plead ignorance. When I first started in practice in internal medicine nearly 20 years ago, before segueing into GI, we'd incidentally find fatty liver, but we really didn't have any screening mechanisms. We had no tools. So we would just simply either brush it off or put it on the back burner, maybe have a chat about alcohol and lifestyle, but really no meaningful impact for these patients as far as reducing risk of liver and non-liver related outcomes. And what we know is that the nefarious part of this is that patients don't know that they have fibrosis, right? And so it's not until they potentially present with late-stage liver disease that we figure out that they have a problem. So it is incumbent upon us, but also our colleagues across the disciplines that we saw in our earlier slides, to identify these patients appropriately so that we can actually treat them to reverse that fibrosis and those comorbid conditions. So we know that patients with specifically F2 or F3 are at higher risk of developing specifically major liver events, which encompasses cirrhosis, the need for liver transplant, and the risk of hepatocellular carcinoma and liver-related mortality. We also know that that there is some variability in terms of how quickly patients progress through these different stages of fibrosis. However, we know once they get to that F2 and certainly F3, that rate of progression is much more accelerated, or one could argue that the window between the stages is shorter, where they can sort of smolder at an F0-1 for a period of time, but then as soon as they jump to F2, again, that window shrinks significantly. So that unpredictability, again, is variable based on those comorbid conditions, other influencing factors, for example, like alcohol, of course, genetics, and the onset of disease severity. But it also means that we can't just sort of put it on the back burner and ignore that. And MASH with fibrosis stage 2 and 3, again, remains mostly undiagnosed and unmanaged until it's too late. So here we look at sort of what is that actual predilection. So once we have identified these patients with F2-3, we know that 22% of those with F3 specifically progress to cirrhosis within 2 years. Blink of an eye, 2 years, okay? Where 33% of those that are well-compensated cirrhotics present to a decompensated state within about a 4-year period. So again, how rapid that process happens changes based on how their initial fibrosis scoring stage. MASH is the leading cause of liver transplantation, specifically in women, as we saw in our opening slides. And MASH cirrhosis is likely to become the leading cause of all highest leading cause of liver transplantation overall. You know, we've done a nice good job of curing hep C and sort of bringing those numbers down. We know that patients with genetic predilections like PBC, PSC, autoimmune, we know that what those predilections are in you know, statistically. So that's pretty even. And the MASH scale is on the rise here. Another concerning factor here is that patients with non-cirrhotic MASH, but that have fibrosis, are at 3 times increased risk of developing hepatocellular carcinoma. And we do a really good job, again, of screening our known cirrhotics for hepatomas. We AFP them, we ultrasound them, we MRI them. But these are folks that have fibrosis with no cirrhosis that still have hepatocellular carcinoma, which we know for the most part leads to mortality. And as we have already seen, sort of the bidirectional relationship between all of our internal organ systems when you have metabolic disease and risk factors. But how I sort of view this is that our liver is a window into the potential severity of outcomes of cardiovascular disease. As we've already alluded to, cardiovascular disease will usually get them, so to speak. However, the severity of that event is more severe and leads to more morbidity and mortality if they have concomitant MASH with fibrosis. So again, it's sort of that lens or window into the rest of the outcomes with these comorbid conditions. So they're at 10 to 17 higher risk of liver-related mortality compared to F0 cohorts, and more severe outcomes in cardiovascular disease. Often what I, not so much in the context of our group today, but what I tell my primary care or endocrinology, cardiovascular colleagues, et cetera, is that, you know, in diabetics, for example, we do a really good job. Have we checked their, you know, creatinine? Have we checked, have they had their eye exam, et cetera, et cetera? Well, in that list needs to be screening the liver, right? Often it gets lost in the sauce, so that has to be on the check sheet as far as screening these patients. So looking here, this is at claims-based retrospective data at just shy of 19,500 patients with MASH. So 22% of that cohort of patient, which was roughly 3,500, were identified of having features of end-stage liver disease of some degree over a 3-year period. And so 50% of that 4,235 were recognized as having features of end-stage liver disease within a year, and 80% of that 4,235 were identified with features of decompensated cirrhosis within 3 years. So again, just speaking to that rapid progression once you've developed fibrosis. As we've already seen, what are some of those comorbid conditions? We see patients that have 1 or 2 or more of these every single day. Even if you're not a liver specialist, I would argue in every specialty in medicine, with the greatest being dyslipidemia and obesity, of course, diabetes and associated insulin resistance and hypertension. I also, in my practice, you know, someone may come in to see me in the GI space for GERD, right? And I may have a conversation with them about, hey, how weight loss can help their GERD symptoms. But also in that person, if they have a high BMI, maybe a BMI of 34, and yes, they came to see me for GERD, I'm usually FIB4ing them or fibroscanning them or doing some screening mechanism, just like I would my due diligence and say, have you had your colonoscopy? You're 45, right? So for me, in a non-liver patient, or a non-obesity medicine patient, which is part of my practice, I will screen those folks as well, even if their primary complaint is not liver specific or weight specific. So looking here in the first and only FDA-approved treatment, again, in conjunction with lifestyle for non-cirrhotic MASH patients. So with this, just want to stress that it is for the non-cirrhotic patient, and do not use this in decompensated cirrhosis, and make sure that we have confirmed that they have F2-3 fibrosis. As far as hepatotoxicity, just a call out here, this was one patient that experienced a significant elevation in liver functions. This patient was not in the MAESTRO-NASH trial. They were in the safety trial, and they ended up having an autoimmune underlying liver disease. So also do your due diligence that they don't have other concomitant liver disease. But it was one case that was reported. As we've already discussed, gallbladder disease is very common with the risk factors that go along with MASH. So compared to placebo, there was slightly higher observed gallstone events, and we'll see those numbers broken down a little bit later. And we'll also look at how we adjust statin doses when you're using Rezdiffra. Of course, a lot of these patients are going to be on statins, and how we adjust for that. So thyroid hormone receptor beta is very targeted at the liver. So when we think of systemic sort of thyroid hormone, when we're treating for, hypothyroidism, et cetera, that's thyroid hormone receptor alpha, which is much more systemic. So this particular subunit is specifically expressed in the liver. And this has been identified as when this pathway is when there's dysfunction in this pathway, that it leads to fibrosis progression in multiple ways. One is when the signaling is off kilter, the liver causes mitochondrial dysfunction, both in getting rid of sort of scrambled mitochondria and making new healthy mitochondria, leading to increased inflammation and lipid storage in the liver, leading to hepatocyte death and damage. So here with this particular product, we're partially agonizing or stimulating this dysfunction or dysregulated pathway within the liver. And by stimulating that, you improve these critical processes such as appropriate lipid metabolism, making sure that they're not overstoring lipids, fatty acid oxidation, but also appropriate mitochondrial function. Again, getting rid of sort of that's what I often refer to as the scrambled mitochondria, and having nice new healthy mitochondria for hepatocyte turnover. And here we also see, again, improvement in lipid metabolism, which reduces intrahepatic triglycerides, free fatty acids, and the inflammatory cascade that goes along with this, which is the driving factor in liver damage in these patients. So the pivotal trial here, MAESTRO-NASH trial design, was a treat-through design. It was a double-blinded placebo-controlled trial. It is still ongoing. This product was approved at an accelerated approval through the FDA, I think speaking to the importance and need of treatment in this space. And so it was pretty evenly distributed between the two approved doses and placebo here. Those dual primary endpoints, which were pretty rigorous, was fibrosis improvement by equal to or greater 1 stage with no worsening of steatohepatitis. Of course, if there's worsening steatohepatitis, you're no better off for the wear. And secondly, steatohepatitis resolution with no change in fibrosis. And I just want to kind of take a moment of pause, as spectacular as it is to cure hep C, right? Because we virtually cure nothing, we manage everything. But I think conversely here, it's pretty remarkable that we can reverse something that's fibrotic and scarred. Because if we think of other pro-inflammatory diseases, autoimmune or otherwise, what is our goal? Is to halt progression. Okay, we want you to be no worse than you are today, right? Whether it's Crohn's disease, rheumatoid arthritis, MS, etc. But here we can actually reverse that train a little bit, right? You can actually reverse that scarring and fibrosis, which is really quite remarkable. And then we see here in these colored little diamonds some other endpoints. This was a liver biopsy-based study, but looking at, of course, adverse events, and then non-invasive testing paradigms like FibroScan and MRI PDFF. There were 2 independent pathologists that independently read each of these liver biopsies. And just when you look at sort of placebo versus treated group patients that were lost to follow-up for liver biopsy, were deemed to be non-responders in the analysis. They did also look at a breakdown of type 2 diabetes, whether or not that changed outcomes, and we'll see a slide about that in more detail. It did not. This is patients that were adults that had 3 or greater risk factors. Again, liver biopsy confirmed fibrosis by MASLD scoring, and then they did look at some non-invasive testing paradigms as well. No one with severe hepatic impairment or decompensation was included in this. It is not studied in patients that have other concomitant liver disease, patients with excessive alcohol use, low platelet count, which of course speaks to cirrhosis, and an elevated MELD score. So kind of looking at our patient demographics, mostly middle-aged, obese patients with BMIs roughly around 35, slightly higher predominance with females, and we know that this is the number one reason women get transplants. So looking at that breakdown, a large percentage, nearly 2/3, had type 2 diabetes, nearly 80% with hypertension. So those 3 or more comorbid conditions, about 15% on thyroid medications, so just calling that out, and about half on statins in some of their baseline LFTs. Looking again at non-invasive testing paradigms and how that broke out. So we're looking at VCTE, obviously CAP scoring and KPA scoring, FIB-4 scores, ELF, and then biopsy. So recently, AASLD practice guidelines on how we position this product in treatment of these patients. So often we're familiar with NITs, but here also NILDA is somewhat interchangeable, so non-invasive liver disease assessment. So VCTE, we're looking at roughly patients with a score between 8 and 15. If you do MRE, 3.1 to 4.4, and then of course if they've had a liver biopsy, you don't need to do a liver biopsy. But if you have the liver biopsy for other reasons, of course, if they're in F2-3. Now, patients that we should not consider this in, again, patients with any degree of cirrhosis, patients that have concomitant liver disease, alcohol use of over 20 grams in females, 30 in males. Just to put that into perspective, that's roughly 2 glasses of wine or beer for women and 3 for men, so not hard to do. And those with active thyroid disease, so that's anyone with hyperthyroidism that's not controlled, or patients that have severe hypothyroidism with a TSH over 10. So we're not talking about the I've had hypothyroidism since my postpartum days, and I've been on the same dose of Synthroid for 25 years. Those patients are completely fine. We saw about 15% of those patients in the trial. The other thing to call out, as great as non-invasive testing is, and it is a great screening tool for us, as it stands right now, there's no FDA-approved NITs to diagnose or monitor them, so just keeping that in mind. As far as those that may sort of fall in an in-between range and may want to be determined with a hepatology specialist specifically, so anyone that's not in sort of that sweet spot of 8 to 15 on VCTE, or maybe it's a little bit gray on whether or not they're truly an F2-3 fibrotic. So looking at endpoints here, so this is splitting up the 2 different pathologists' endpoints in placebo, 80 and 100 milligrams. And so here we can see statistically significant difference compared to placebo in both of our doses here when you split apart the 2 pathologists. And this is specifically looking at fibrosis improvement alone, so not the 2 endpoints together in the total population in the study. Here we're looking at sort of all comers as far as the results of the pathologists combined here. And so what we see is 1.6 to 2 times as many patients that were on Rezdiffra versus placebo achieved fibrosis improvement, which again I think is quite remarkable that you can actually reverse something that is essentially scarred. Right. And this is fibrosis specifically. We'll look at here at steatohepatitis in a second. Now, this was something that the FDA wanted or did, and essentially what this looks at is, I mentioned earlier that patients that didn't have had missing biopsies by the end of the study were sort of put into the placebo bucket. That's not unusual. We see that in a lot of trials. But basically what they did here in the paired biopsy imputed analysis is, okay, taking those folks that, were missing biopsies, if we, sort of account for what their anticipated outcome would have been. And so we're looking at that here. So nearly double really compared to placebo, specifically in fibrosis improvement here by week 52. Now here we're looking at the split, again, the two different pathologists specifically in the resolution and improvement of steatohepatitis. So separately from the fibrosis, even though it gets a little bit confusing with no worsening fibrosis, this is strictly looking at the resolution of steatohepatitis. Again, statistically significant difference compared to placebo here. When we combine both pathologists' reads, we see here that up to 3 times as many patients taking Rezdiffra compared to placebo had a resolution in steatohepatitis. So again, pretty remarkable that that essentially completely resolved. And if we take into account some of those missing biopsies and how those populations, those patients had been part of the full study population, how they would have behaved is certainly statistically significant here, up to 40% in our 100 milligram arm. All right, and I'm going to turn it over here to, she's right behind me.
Thank you. Well, that was a great summary so far. Now I've got a little bit more information to add. We're going to take it from here. When we look at the information to date, there's a lot of questions that will come up. Are there certain patient types that would respond better, whether it's related on age, whether males respond better than females, diabetics versus no diabetics, if they're on GLP-1s or not, in the fibrosis stage. And across the board, there was not a difference in the response rate with these populations. When Jen was just talking about the patients who, with the imputed data, they didn't have a liver biopsy at the end. And the reason for that is these studies were conducted during COVID. So some of those patients weren't able to come in for that second biopsy. And to me, that kind of explained a lot more on why there were so many missing biopsies, but it was just the time that we were at. So anyway, no difference between all of these. Let's talk a little bit about the safety profile. This is a robust safety profile. Rezdiffra has a demonstrated tolerability profile. This is not done in percentages. It's actually done with an EAIR, which is, from a research perspective, even a little bit more sensitive. If we look at on the left side, the adverse reactions, diarrhea, nausea, pruritus, we'll see that there are some patients on placebo that have these side effects, and some with the 80 milligrams and a little bit more with the 100, which we would expect. We're going to break this out a little bit more into the two most common. But if we look overall, there's been over 2,000 total patients that have been studied, and the first 1,050 patients entered this trial for the MAESTRO-NASH more than 3 years ago. There's very few patients that actually have adverse reactions that lead to discontinuation. So the most common GI side effects are going to be diarrhea and nausea. They were mild to moderate in severity, typically beginning early in the treatment. So in the diarrhea arm, you're looking at the diarrhea arm. In diarrhea, patients on Rezdiffra 80 are going to have diarrhea that develops around day 17, and with the 100 milligrams around day 6. This is just kind of a reminder to look at the patients who may have diarrhea and nausea before they start the trial and make sure that you're addressing that. So if they have lactose intolerance, perhaps they need to make dietary changes. If they have other dietary sensitivities, so that you're not dealing with someone who's got underlying diarrhea that then gets worsened. So if somebody comes in, I definitely have been asking about their nausea, make sure they don't have GERD, make sure they don't have strong use of non-steroidals that might affect the nausea as well, and address those before they get started on medication. Laboratory parameters, again, very important for us to look at. With hepatitis C, we had a certain regimen and way that we would see the patients, get them started on treatment, and then monitor whether it was week 4, week 12, whatever your practice would decided to do. But the data here really looks at helping us in practice determine where we're going to do the testing on these patients. So starting at week 12 through week 52, there's a trend for greater reduction If you know that the patients are going to start on this medication and at week 4, they're going to have a spike in the ALT. It'll come back down around week 8, and it will even be lower at week 12. In our practice, this was helpful. We now do our first blood test on patients at week 12. Because if we're doing it at week 4, as you may know, patients typically get the results of their labs before we do, and they would be very concerned about numbers being up. So it's easier just to say, this is a long-term medication. We need to get you started on this. We have communication through our portal with our nurses, and if I go back to where we had the side effects with Rezdiffra 80 with the diarrhea at day 17 and with the Rezdiffra 100 at day 6, they're checking in with us at week 2 and then again at week 4 with any side effects that they might have. And my medical assistant kind of will then draw that to my attention if a concern arises. So as we look at the ALT, we also see a very similar pattern with the AST, again telling us that it may be better to wait until week 12. Laboratory parameters, patients seem to like to have fibroscans done, but we need to encourage them that this is a long-term process and that getting them started on medication is not going to immediately cause the fat in the liver to improve significantly. So I would just encourage you to consider that the reduction in liver fat with both Rezdiffra doses was observed on MRI PDFF at week 16, but not on a fibroscan typically until week 52. So it may be better to wait until you're a year out from starting this to repeat a fibroscan if you're wanting to show some improvement. And if the patients understand that up front, because they're familiar with what the CAP scores are, so if they know that we're not going to be doing this, then it seems to work better. Thyroid function studies, you can do whatever type of testing that you would like. If I have a patient who's under the care of an endocrinologist, they may want to do the T3 and the T4. Typically, we do a TSH, but we'll add that to whatever the other specialists are doing. And when we're looking at the AST and ALT, just kind of to remember, your patients may be under your care, but they may also be seeing a cardiologist and an endocrinologist, and somebody else may be doing blood work on them as well. So to let the patients know, if you do have labs done before their 12 weeks, contact me before you get real concerned, because this may be a little bit of an increase so that they're at least aware. So oral once-a-day daily dosing Rezdiffra is changing the world. As you have seen in the previous talks, there's such a tremendous awareness now for MASH. My little story, I had a 19-year-old that came in who had been sent in for a fibroscan because her abdominal imaging showed fatty liver. Both of her parents had been told that they had fatty liver, but it was not a big deal and they should not worry about it. So they both ended up coming in as patients, and Dad had cirrhosis and he had no idea. So the daughter had severe steatosis and she didn't meet criteria for this drug, but the awareness is now out there. I have patients every day that come in and say, why didn't they send me 2 years ago? I've known about this fatty liver change, but they told me not to worry about it, that everybody had fatty liver. So as we're talking about cardiovascular risk, typically with cardiovascular disease, we're being reactive. We wait until something bad happens. Now we've got the opportunity, and I feel like every day I'm handing a patient a gift. You've been identified now as having a risk. We can put things in motion to actually change the course of how this is going to progress. So Rezdiffra, oral once daily tablet that can be taken with or without food. 2 doses, 100 kilograms or higher for the Rezdiffra 100. If it's less than 100 kilograms, you do the 80 milligram. There are some other medications that will need to have dose reduction, and we'll talk about those in just a moment. So dose modifications and concomitant use. This is really important, but I'll just caveat this by saying, when you talk to your patients, find out who they are under the care of. I'm in Colorado. We have people who have care through the military organizations. I have patients who get medications through the VA. If you have a specialty pharmacy that you're working with, that specialty pharmacy may not know what the VA is prescribing. So it's important for you to kind of get an idea of where patients get medications from so that everybody's talking together. So you're going to need a dose reduction in Rezdiffra in patients who are on medications like clopidogrel, and you've got some specifics on how that's going to be done. And concomitant use of Rezdiffra with the strong CYP2/CB inhibitors like gemfibrozil and cyclosporin are not recommended. If you think about this, these three medications between the clopidogrel, the gemfibrozil, more so those two, are things that our patients may end up needing to be on at some point. So how many of these patients are going to be at cardiovascular risk for a clot? How many are going to have DVTs? So what I'm counseling my patients now with, if you start these medications, they actually get a little printout from us that states during the course of this treatment, since it's going to potentially be several years, you may have the need for certain medications, either to be started on something like clopidogrel, or if you have a cardiologist, they may want to look at the gemfibrozil or the statins or increase the doses. So I want them to be aware of these things, even if they're not on them now, because during the course of their treatment, they need to know if that changes to be in touch with us so that they can make some alterations in doses or stop medication if that's necessary. With statins, an increase in exposure to atorvastatin, pravastatin, rosuvastatin, and simvastatin, when concomitantly administered, may increase the risk of adverse events. You must limit the daily dose of rosuvastatin and simvastatin, pravastatin and atorvastatin to just the 40, and monitor patients for potential side effects. What I like to do is find out who their cardiologist is or who is prescribing their statin. I will then send them a letter stating, we're starting this medication. If you have a change in dosing, we need to discuss that before that's done, just because of the safety that we need to ensure for the patient. I think as we're trying to pair with our other colleagues, whether it be endocrinology or cardiology, we really need to have that line of communication that's open. So reviewing a little bit on the safety data, the most common adverse events are going to be diarrhea and nausea. We all know how to manage that. If we can proactively manage that ahead of time to try to minimize or let the patient at least have some ideas on what they can do more on a dietary basis, that's always good up front. There are some concomitant use medications that should not be used. The gemfibrozil is one, and the cyclosporin and clopidogrel may need some dose reduction along with the statins, and we've gone through that. So certain populations we don't see, we don't have any data, so there's no available data on Rezdiffra in pregnant women. There is a reporting number that you can call if a patient that is on this becomes pregnant. There's no information regarding lactation. Interestingly, numerically higher incidence of adverse reactions have been observed in patients who are greater than age 65. It's kind of hard to think of geriatric, but I'm getting closer to those numbers. Renal impairment, we don't have studies in severe renal impairment, and hepatic impairment, again, to stress. This is not to be used in patients who have compensated or decompensated cirrhosis. It's going to be for patients who have F2 and F3 fibrosis, hopefully catching them at an F2 so we can start this whole process earlier. So patient access to Rezdiffra. You can enroll them through the Madrigal Patient Support Program. It's a wonderful form that you fill out. You send this to the specialty pharmacies. So this is good and well, but what I have found is that if I add information, including their BMI, what their comorbidities are, what their fibroscan showed, if I have an ELF, all of that information, when I send this to the specialty pharmacy, then if it is denied, they have the firepower, and they've actually been working with me to formulate letters for the appeal process. So since we were having some denials, and sometimes it was really due to lack of information that the insurance company was saying we need more. So I like to front load them with as much of that information so that my specialty pharmacy has an easier time in getting these medications through the appeal process, if you will. And the Madrigal Patient Support has done a great job with this, but again, without the data up front, they're not going to be able to kind of show the insurance companies and support the reason for this medication. So the case managers are great, nurse navigators, patients have questions, they have somebody that they can contact at all times. Non-invasive testing program and actually payment for that is another feature. As we all know, non-invasive testing is usually going to be a combination. There's never just one test that is done that's going to help determine what's going on. In our practice, we have our fibroscans that are done on patients who are hopefully non-fast, or they're fasting when they come in, but if they have numbers that are significantly off and kind of discordant with what the rest of the labs show, we have other nits that we can use. So if we need to do that and it's a cost issue, it should not be, because Madrigal will find a way to help offset that. So Rezdiffra is the first and only FDA-approved treatment for non-cirrhotic, again, focusing on the non-cirrhotic MASH with moderate to advanced liver fibrosis. Dual efficacy, which has been very strong in the studies, which is then what led to this being approved at the rate that it was. The safety profile with now over 2,000 patients that have been studied. Rezdiffra works directly with the liver by stimulating the thyroid beta to improve critical hepatic process and kind of work on the triglycerides within the cells. Once daily dosing, and you don't have to worry about taking it with or without food. This is really where we are at. I would say I'm going to leave this slide up there. It's an honor for me to have presented this information. I have tried to throw in a little bit of, after now being able to prescribe this for patients for almost a year. You learn the little nuances on what to do when you get the denials and how to counsel patients who end up with clots and then end up on clopidogrel, and you don't want to jeopardize this medication. I had a patient recently that was going to be started on gemfibrozil, and so he called and he said, I think you told me that was one I wasn't supposed to be on. So he went back to his doctor and said, I'm not stopping the Rezdiffra, so they were able to come up with a different medication for him to be on. But again, this is the awareness of what we deal with patients on a daily basis now that we have the opportunity to use this medication. So again, I'd like to thank Madrigal for the opportunity to provide this information. I don't know, Jen, if you want to come up and if we have time for some questions before we move on to the next part of our evening. So thank you. I don't know if there's questions because I...
Thank you. I don't know if you're going to be able to speak to this specifically, given the firewall that happens for data, but what I just looked through is a meta-analysis and review of its effect on cholesterol. So it does look like it actually lowers LDL cholesterol by about 23%. And so I'm okay as a preventive cardiology PA seeing someone drop down on their statin, because you double from 20 to 40, all you get is a 6% further decrease in LDL. You add this, and you get a 20% decrease in LDL. So I'm okay in backing off statin doses. And by the way, gemfibrozil gives me the same metformin. So stop doing that. Geez, stop that. Anyways, I don't know if that's something that you've seen clinically outside of this data, if you're noticing it, because I've not prescribed Rezdiffra, but
The molecule was looked at initially was in that space. I don't personally recheck their lipids. I still deem that with their PCP or their cardiologist, but I've had few that I've had to dose adjust, but no one has had a reservation about it, I think, because of that.
All right, well, thank you very much for the opportunity to present, and I'm really looking forward to the weekend.